Welcome to tonight's M&M. It's called the A's and B's of Care at Home. What a great crowd. Thank you all so much for coming. I hope that we help you get some clarity on this kind of confusing topic. So before we get started, I was asked to do some housekeeping items. At the table in front of you, you have some surveys, or you should have a survey. We ask that, basically this is our way of figuring out what you would like to hear more about, future topics. So please take a minute to fill that out. Any questions you may have during the talk tonight, I always find it good to write it down because I'll forget by the time I get picked. And I wanted to remind everyone that our next M&M is on May 18th, and it's about outpatient therapy. So I hope you can join us for that. So, first I'll introduce myself. My name is Peggy Coburn. Once again, thank you so much for joining us. And I think probably, what's the goal of tonight? I don't think we're all here because we're looking forward to the day we have to move into a nursing home. I think we're all trying to figure out how to stay home, how to stay healthy, and how to stay safe. So, why do we have to have a panel on that topic? I think you probably know, I certainly know as a healthcare user that the healthcare system is confusing. What kinds of care there are out there, where are they offered, how do they get paid for? We don't make it easy in our country to figure out what we need to keep us healthy and safe at home. So what we've done tonight is to assemble a panel of experts, and their focus, is how do we get care at home, which is the right amount of care in our home when we need it, and how do we become educated consumers to be sure that we access what we need. And I think what you'll find is that the different services that the folks who are on our panel, these services can sort of be used as a continuum. They could be standalone, and sometimes they can work at the same time for us. Now, also in front of you, there's a handout called the A's and B's. On the front side of it are service options, and they represent the ladies that are here on the panel. And on the back are the various different ways these services can be paid for. Just for you as a resource to look at while we're talking about things. So keep that near you. But first I'd like to start by introducing our panel. I'll start with, what I'm going to do is offer a bio for each person on our panel, and then I'm going to ask them to give you a very high-level description of what they do. Incredibly bright women who I have no doubt can answer all of your questions. So I'm going to just start with me. I'm Peggy Coburn. I'm the administrator of McLean's Home Care and Hospice Agency. I've been with McLean for about 7 years. In my past life, I'm a licensed nursing home administrator. I was an executive director of an assisted living that cared for people with dementia. And way back in my life, I was a social worker who would go out into people's homes and try to help them get services to keep them out of nursing homes. So that's my varied background. What I'd like to do is introduce you to our panel. I think many of you may know Tully Meyer. She also works for McLean Home Care and Hospice as our community liaison. She's been with us for about 6 years. And Tully came to us with many years of experience in various different settings in healthcare. But she's found a home with us all here at McLean. Sitting next to her in the middle is Kim Quinn, who is an account manager for the Hartford region of Fox Rehabilitation. Kim has been with Fox starting in Connecticut for the past 10 years and has a strong history of building relationships with doctors, hospitals, clients throughout Connecticut by educating on the importance of wellness and rehab in your home. Fox Rehab is what we would call an outpatient therapy service. And then on the other side of Kim is Sandy Cook. And Sandy is the Manager of Business Development and Care Coordination for Home Helpers of the Farmington Valley in Central Connecticut. And Sandy's been in the industry for over 15 years. She's a certified senior advisor and a dementia practitioner. She also volunteers her time as a community educator and a support group facilitator for the Alzheimer's Association. So as you can see, we've tried to put together a panel of experts that hopefully will help you with any questions you may have. I'm going to ask each of them to just give a little bit about what their service line does. And then what we've done is the four of us have created some scenarios that will kind of illustrate how these different services fit together. Then we'll finish up with questions and answers. So, without further ado, Telly.
This is likely the second time some of you have heard this spiel, so I'll keep it brief. I represent a Medicare A service, which is if you have a decline in function or you have a surgery, a fall, an illness, and it's physician driven, so it's a visit to your doctor's office or it's a trip to the hospital, we come in and help you get better quickly. So we have skilled nursing, physical therapy, occupational therapy, speech therapy, home health aides, and social workers who will come in. Social workers are your resource providers. They know all the different resources you might need. And we can come in with all of our services, a portion of our services, depending on what you need. We're in and out. We're a short-term rehab service in the home.
And this will be my first time telling you guys about Fox. I'm with Fox Rehabilitation. We are an outpatient physical therapy, occupational, and speech practice that only treats in the home for the older adult population, the Medicare population. So we use your Medicare Part B benefits, which is your outpatient benefits, like when you go to a doctor's office or if you do go to an outpatient clinic for physical therapy, we tap into your benefits under outpatient. And we can come to your house, and this can be one-on-one, so you don't have to go to an outpatient clinic. A lot of times we work with patients before they have the catastrophic fall that may put them in the hospital before they need Medicare Part A. So your doctor might say, hey, geez, you know, your balance is off a little bit, you might want to get some physical therapy. And then we work after Medicare Part A, after McLean has been in and been your services to get you back up on your feet. Many times you need to continue with therapy, and we are what they call the continuum, and we can continue on. But a fun fact is A and B cannot run together. Medicare says, no, 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 you can only have one at a time. And so that's why we work really well together as the continuum, because when you're finished with A and you still need more services and you want them to come to your house, then you can go to B. So that's Fox Rehab.
Thanks. Hi, I'm Sandra Cuck, and as Peggy said, I'm the Manager of Care Coordination and Business Development for Home Helpers. So we are a non-medical home care company. We are not covered by insurance unless you have long-term insurance. That piece is what people usually do ask. And we can work in conjunction with both of them. Typically, I like to say, if you noticed, the brochure that I put out says recuperative care. Many times, individuals like yourself call us because you might be having a knee surgery or some different type of surgery and you just need a little assistance, or somebody is telling you you might need a little assistance to come home and be safe, right? That's what it's all about. So we do a lot of recuperative care where we just come in, help out for that time being until you're back on your feet. If we're getting calls from the children or a spouse, then that becomes obviously a little bit more of a critical situation, right? A spouse is taking care of a loved one who might have some cognitive issues, Parkinson's, any specialty, type of disease, and needs a little bit more assistance in the house. They cannot do it all alone. If we get a call from the children, we know there's a problem. because mom and dad may not be talking to them, or, you know, if it's a niece or nephew or whoever that, you know, is helping out as your power of attorney, is realizing that there's a bigger issue and, you know, someone needs. So we're just there to be able to offer the assistance of what we can do. So it can be from a few hours to 24/7 to providing a live-in so that you can remain independent in your home. So that's what Home Helpers does.
So on your sheet, I learned something new when I was preparing for this, which for home care / private pay, which is the last item on this, assistance, some of the services that get provided by a private pay home care agency, activities of daily living, which we think of as showering and dressing, feeding, toileting, but Sandy introduced me to the concept of instrumental activities of daily living. And that's the grocery shopping, that's housework, that's sometimes transportation. So there's a lot of different options out there depending on what your needs are. So I hope you find this helpful. I know I learned a little something when I was typing it. So.
And Peggy, I might just, thank you for that clarification, because I might just add, if somebody does have long-term insurance, we do be able to need to identify what help of daily living activities or instrumental activities that you need assistance with so that your long-term insurance would cover it. So thank you for that clarification.
Okay, so we developed a couple scenarios. I hope you find this helpful. Trying to figure out how to really fully explain to you how all of these different services sort of interconnect. If it's not super helpful at the end, you know, questions and answers, that's how you really get the information that you want to know. But our first scenario that we developed, Joe Smith fell and fractured his hip and ended up in the hospital with a hip replacement. Joe lives alone and he lives in a 2-story house. Tully, what would home health care look like for Joe?
It would likely look like nursing, physical therapy, occupational therapy. If there's an incision or there's any kind of medication management post-surgically, a nurse would be warranted. And then you'd have your physical therapist for endurance and your occupational therapist to teach you how to get around the home with your if there's any restrictions.
Can you have could you just have physical therapy?
Yes.
Okay.
But with home care, under a Part A benefit, you must be homebound. So therein lies the little bit of the rub of the whole thing, is that you can go out sporadically, but your typical day-to-day life is a taxing effort to get out. And you'd be qualified then for physical therapy, and then you can also have occupational therapy. Occupational therapy can't stand alone under our model. It has to come under physical therapy or skilled nursing, but physical therapy and occupational therapy can stand alone, as well as nursing. If you just need a nurse, you have a wound, but you're moving around fine, you're just not up to going out and living your usual life, then just a nurse would be warranted.
And just to clarify, these are Medicare rules. These are all guidelines, both the outpatient therapy and the home care. These are guidelines that are set out by Medicare that we have to follow in order to bill your Medicare. So let's say Joe finishes his home care episode with McLean, but he's still not quite back to where he was before he fell. I know Medicare can sometimes limit how long someone can be in there, and Joe's maybe ready to get out of the house a little bit. Kim, how could you help out Joe to get stronger?
So what would happen is that usually the physical or occupational therapist will identify that they're getting ready to discharge and recommend that Joe, and this is McLean their PT or OT would recommend, I think you need a little bit more the physical therapy to work on the exercises we were working on so that you can continue to reach your goals, so you can continue to do what you're doing. Because let's face it, anytime you're doing physical therapy, if you follow your plan of care, such as 3 times a week for 3 months, you're going to get better. It's like taking medicine. So if you keep on doing things with durations, longer durations, and more activity, you're going to get better. And so what would happen is the physical therapist could say, hey, listen, Joe, I think you need some more physical therapy to continue on. Now that you're the end of the episode under Medicare Part A, Medicare is telling me I have to go ahead and discharge, but you can get Fox Therapy to come in and they can work with you in one-on-one, just like I am in your home. And at this point, you can start driving if you needed to, if you wanted to get out of the house, because there aren't the homebound restrictions for Fox to come to the house. And so PT, OT, and speech can come in if you needed speech. Obviously, in this case, you wouldn't need it, but they can continue to work with you until you've gotten to the goals that you feel that you want to get at, or we feel that you're safety at. You can't have therapy for the rest of your life. I mean, some people want to have it all year long because it's nice to have someone come to you. But Medicare says as long as the skill is needed, as long as it's medically necessary, you can get these services, whether it's through Tully or myself. There has to be medical necessity. Once you are able to do the skill set yourself, that's when you can't use the insurance anymore. But the goal is always to get you to a point that you don't have to use our services anymore, that you can perform that skill on your own.
So it's not dissimilar if anyone has gone to an outpatient physical therapy. There's a beginning, middle, and end of services, and you make progress, and then one day your physical therapist says, okay, I think we're set. We can discharge, and they may give you some exercises to do on your own. But because Medicare is paying, they're very clear on the guidelines about how long any of these services can happen. Now, Sandy, I'm wondering if, Joe Smith's daughter shows up after Dad's broken his hip and kind of realizes, doesn't look like Dad's been able to keep up with all the things around the house. How could you possibly help Joe kind of right his ship? He's operating with a kind of repaired hip, and he's got this 2-story house he's trying to take care of. So how could you guys help?
Yeah, so kind of what we initially had talked about, recuperative care, helping somebody, because what we have to remember with the services that both McLean and Fox provide, the therapists are coming in and out in probably about an hour's time frame, right? So there's nobody there for any extended period of time, nobody overnight, so we have to look at that safety issue. Obviously, if they're recuperating, some of the instrumental things like laundry, meal prep, what we're trying to do really is keep the individual out of going back to the hospital or rehab or wherever they're coming. And what we find is that when individuals go home and they live alone, sometimes what ends up suffering is they forget to take their medication, or they're not taking it on a timely basis, which could be important, right? Nutrition becomes an issue because now they have a fractured hip in this particular case, and they can't really do meal prep. Yes, there are some things that you can bring in, but I recently talked to somebody who his kitchen was on the first floor, but his bedroom was on the second floor, and it was very difficult for him to get up and down. So, you have to, look at those, issues. So again, it really is about keeping them out of, if they've been in a rehab or a hospital, or just really keeping them safe at home and avoiding a crisis.
Okay, scenario number 2. Mary Ellen Jones, you can tell I was so creative in these names. Mary Ellen Jones goes to her doctor for her annual Medicare wellness visit. Anyone do that in the room? Anyone have an annual Medicare visit?
Oh, I know Medicare, but I've had a whole wellness visit.
And while she's there, Mary Ellen actually confesses to her doctor that she's had one fall and a couple of near misses. And she's generally very healthy and pretty active in her community. Her doctor is thinking, near misses, one fall, what can we do to try to protect Mary Ellen from having this go further awry? So Kim, can you talk about how that would work?
Absolutely. So the doctor would identify the issue. Most of the time, they're looking at your gait and your balance. If you're shuffling your feet, if you're losing strength in your lower extremities, it could even be your upper extremities. And the doctor would then send what we call a referral to Fox. They would obviously ask you, do you prefer to have someone come to the house, or do you want to go to an outpatient clinic? Because we're outpatient on wheels and we come to your house, it is one-on-one in your home, and we're working in your environment to keep you safe and stronger and living at home longer. So the benefits would be to sit and start to work on how you get in and out of your chair. Where was the fall? What prompted the fall? What were the things that may have led to the fall? And we can also do a home safety evaluation to help eliminate some of those reasons why the fall was there. And after a period of time, we could leave you with a home exercise plan that you can continue on your own so that you can continue to stay stronger and not have a decline. The nice thing is that in the event that something does decline even further, we're just a phone call away of calling your doctor, who then can reach out to Tully to get nursing to come in. So we work in conjunction together, and then get Sandy out for the needs of the IDLs or the ADLs, and have someone help within the house. So we kind of try to work together as like a circle where we come around.
And I think, the great thing about outpatient therapy in your home, in my opinion, is you're getting your therapy in your setting. So, is your living room carpet a little bit taller than your dining room that's hardwoods? Do you have one step from your garage into your kitchen? It's therapy in real life. I think sometimes when we go to facilities or we're outpatient, you're in a perfectly ergonomically correct setting. The floors are all even, there's space, they have nice sturdy tables, they don't have your favorite chair that maybe is getting a little bit harder to get out of. So the great thing about having part outpatient therapy is it's one-on-one and it's in your home. So it's real time, real life, what's your environment like? And so part of our scenario, which Kim alluded to, she kind of snuck it in, is that while Mary Ellen was receiving rehab services with Fox, at her annual wellness visit, the doctor switched up her medication regime. And so now Mary Ellen's kind of experiencing some side effects. She's not managing her meds as well. There seems to be something else going on. So Kim, what would your folks do if you're in there providing therapy services and you're seeing a change?
So the therapist would then notify the doctor's office that there's been a change. The most common is the blood pressure. We'll see a lot of fluctuation in blood pressure. Obviously sometimes you have to call 911. You never know. Sometimes you call the doctor's office immediately, and most of the time we'll say to the doctor, we work with this home care agency, we recommend that you give a phone call to them, and then the doctor would then call the patient, see them, and determine that they do need home care, and then call Tully. And at that point, we would discharge because, again, we can't treat at the same time, but we can certainly lend to each other and help each other out in giving the information so that you're clinically always getting the best care. So we may want to turn around and talk to the nurse that comes out to let her know what we're actually seeing and passing on that information. So you're not retelling the story over and over again.
Thank you. Okay, scenario number 3, and I promise this is the last one. Joan Finch is a primary caregiver for her husband, who was diagnosed with Alzheimer's disease 2 years ago. Joan is finding it harder and harder to get out, to go shopping, or even to see her friends. She's exhausted. She's continuing to be the primary caregiver, and her adult daughter comes for a visit to see how things are going, and her daughter sits her down and has a heart-to-heart with her, and talks about getting some help. Sandy, what would that look like, and what kind of help?
So there we go with the conversation when it gets to the daughters or the sons or, somebody who's helping, right? Because we all know that everybody wants to remain independent, and we get that. And that's what we're there to do, is to foster your independence, not take it away, but certainly keep you safe. And I always say there comes a time sometimes when you have to call uncle. And in this particular case, every case is individual and specific. So we would obviously include, I forgot her name, was it Mary?
Joan.
Joan, thank you. We would include Joan and her husband, because again, I'm a community educator for the Alzheimer's Association, so we never want to leave out the person that we're taking care of, and we can, in a very caring way, find out what their individual needs are, what the needs would be for Joan, and then customize a care plan that we would then share with a caregiver that we have identified. So it could be just companionship, it could be helping out around the house, doing some laundry, light housekeeping. It could be any types of engagement with Joan's husband. Again, just knowing that she can go out and do her errands or whatever it may be, and that individual, remains safe. We ask questions right down to the fact is, if it is a male that we're taking care of, would you prefer a male caregiver? Because there are male caregivers, it doesn't have to be a female. Obviously, if it's a female we're taking care of, it will always be a female. I know hospitals and things are a little bit different, but we really do just want to know, as I said, both how we can assist Joan and her husband. And then the key piece about it is, if they've never reached out to these two individuals, the way our system works is that the caregivers have to follow the care plan and identify if there's any change in condition. If they identify there's a change in condition, that's a red flag for me as the care coordinator, that I have to evaluate what's going on. Has something changed from when I went out and did the initial assessment? And then, again, if it's a skilled need, I'm gonna call McLean. If it's just because they need some physical therapy or OT, just to get a little stronger or whatever, I will reach out to Kim. So it works the same way, is that we can identify a change in condition and make sure that that individual stays safe.
I think you bring up a great point, in that all of these services, we have an identified patient that we're caring for, but we frequently have a spouse who's part of this equation. And so all of our services take into account, Joan was the wife who was a primary caregiver. In so many ways, Home Helpers is actually helping Joan too, because it's allowing Joan to have some time to have her life. And if we don't take care of ourselves, nobody else is going to, but if something happens to the caregiver, the whole plan falls apart.
That is correct.
So I think, that's the wonderful thing. And I mean, I could imagine that Home Helpers is in there, and our scenario says that Mr. Finch needs some outpatient services, but I could imagine that maybe even we identify that Mrs. Finch is a little wobbly on her legs, and so she may end up needing some outpatient therapy from Fox.
Right.
So I guess that's where, we're trying to share the story, is that these are 3 different services. They get paid for in different ways, but ultimately, the goal of all 3 of these services, either standing alone on their own or in conjunction with one of the other ones, is to keep everyone home and safe, and being that resource. So as we discussed, you could do a continuum of care. You could just have home helpers who are doing private duty, or you could have a combination of any of them. And what's super important for everyone when you're trying to be that good educated consumer, which is why everyone's in this room tonight, is we want to be a good consumer. We want to understand what's out there. We want to understand how things are paid for, is to fully understand what your benefits are and how things get paid for. And knowing that there's always options out there. And these are three, services that we stand behind at McLean, but there's multitude of other providers out there. And it's just important for you to understand what it is you need, what you would like, whether it's realistic, and how any of these people could help you with that.
And I might just also share, Peggy, if I might, because I know this is how we all work together and why we're here, is that we're also resources. We're out in the field as professionals, so we sometimes identify, people can ask us other questions and other needs that they may have, that we can also share resources. What we say is the last place you want to call is your insurance company, because it gets a little confusing about what they may or may not offer, but because both of these are insurance driven, they certainly know what United Health does versus Aetna, whatever they may be. In our particular case, if you're losing long-term insurance, we understand all the give and takes of that too. So we can intelligently and helpful answer your questions so that you're not, confused. I think that's an important piece when it comes to any type of insurance.
And I would agree that, we say this in the home care office, that we may not, at home care, McLean Home Care, we may not always be the answer to your problem, but we hope we can help you find the solution. So it might not be that home care is what you need, but the folks in the office understand what the other options are and will guide you to say, have you thought about this? Maybe you could look into this. So don't ever hesitate. There's no, the only, what do they say? The only stupid question is the one you don't ask. So please see these folks all as opportunities to learn more and for you to get your questions answered. So that's our scenarios. I'm dying to know if they were at all helpful.
We're seeing a few nods.
And I'm wondering if anyone has any questions. Sure.
I was just going to ask Sandra, what kind of training do your home health aides get?
So I'm going to repeat questions so everyone can hear them. And the question was wondering for home helpers, what kind of training her caregivers get?
So I can answer that. We don't hire anyone to work for us that doesn't have some past experience. So it's a little bit different in the home care industry because we are non-medical. We may have CNAs working for us, home health aides, but believe it or not, the Connecticut law says that we can't say that. Yes, that's God's honest truth. So what we can identify is the difference between personal care, if you need personal care assistance, if you need care with transfers, if you have mobility issues, if you have cognitive issues, any of the, or just companion care, and then identify the right caregiver based upon their experience that they bring to the table. We also just do our own training with them, and we do have 3 CNAs on staff that are also out in the field or do scheduling, and if we need to go in and do one-on-one, especially with transfers, because transfers to us is if somebody's getting up out of a wheelchair to a walker or bed or, different things like that. Again, everybody's a little bit different. We just want to make sure that, we're doing the best, transfers for them. And if not, then that's when we call on them too.
Yes.
Do you have sufficient manpower to fulfill your needs, qualified?
Well, I know I can only speak for home care and hospice, and I would be a liar if I said to you that workforce is not an issue for healthcare right now, but we are fully staffed in home care. I think that we are always looking for great people to be able to expand the services that we can offer and the distance that we can go. So we are in good shape. I don't know about the other ladies. Do you know anyone who's looking for a job?
Yes, no, we're at Fox. With outpatient rehab right now, most companies, what they do is they do scheduling for you. So you would then schedule your appointment based around what your needs are. Unfortunately for us, we have to get a referral from a doctor and check your insurance. So sometimes that takes a little bit of time. Not all doctors do things immediately. And so we try to manage the process. But our coverage is almost all of Connecticut. We're in 27 states, so we're in the neighboring states as well. But for this area right here, we do have plenty of PT and OT coverage. I don't have speech right now, but I have physical and occupational therapy.
And I guess I would also lie that I would say that there's no worker shortage, because you all see it, right? But the thing is that we're constantly hiring, we're looking. The thing is that if somebody can be a little flexible with time, then we can accommodate people. If everybody wanted 10 to 2, because they don't get up early, and they need that assistance, then we would almost have no one, right? So there's gotta be, sometimes just a little bit of flexibility on days and times that, we can, best work with you. And again, there are times where, we have a full bench, and other times that we can't. We are okay with knowing who other home care companies are and, referring you. Gone is, I will just say this if I can, somebody calling saying, I just need a couple of hours. That is, caregivers want to work, right? We all know this after, COVID and everything else. They have families to support. Minimum wage for them is going up to $15 on June 1st. We're trying to make it better for these individuals. So, they do want to work. So saying I just need somebody for a couple of hours may seem like you can, but again, do you really want somebody to rush through something and be just task-oriented, or, do you want that involvement? So
Sandy, do you have a minimum hour? Or do you not want to go forward?
No. Currently, right now, we're very able to, staff 4 hours and up. And we do a lot of overnights. We do a lot of live-ins with overnights because of cognitive issues. So, yes.
So, and it's not 4 hours every day. You
That
could
is
do
correct.
3 days a week if it's a Monday, Wednesday, Friday, or whatever. So
2 days a week,
you do
yes.
have a 4-hour minimum. So
Right.
that's important for you to understand. That, I will tell you, I think is pretty much the standard out there. I know of very few agencies or companies that can go less than 4 hours for the reasons that Sandy says.
I like the way you share information, but I have a question. Who do you call first?
What is the first phone call that you make when you decide you need help?
Well, I would say you could actually call any of us. I would love for you to call home care first, because that's who I'm in charge of. But, as I referred to earlier, if we can't help you, if what your story is that you're telling us doesn't sound like it will be, that you're not homebound, that you don't have some new life event, or you don't have a doctor's referral, we might tell you, I don't think home care is what you need, but let me give you the name and the number. And Tully does this all the time. She'll give you the name and number of who she thinks might be your best first step. So I think I would never, who knows what's first? Who really? There's so many factors that go into this. But I think you could reach out to any one of us and tell us your story, and then we can help you figure out, I think maybe what you're really looking for is outpatient therapy. Or, no, I think you would qualify for home care. Or it sounds to me like you need some help with caregiving. Don't be afraid. I guess the answer here is, it's a great question who to call first. Just call somebody, any one of us, and we'll try to help you out.
The phone rings all the time in home care, and it's not a true Medicare A home care need. It's somebody more asking for private duty. So I can't tell you how many times a week that happens, but that's great, because we have our list of private pay agencies that we work with. I know the person who's in the community, I know their reputation, done all that kind of legwork for you, so that I know when I'm giving you the name of someone that it's not necessarily that McLean has vetted them, but they've been with the company a long time, all the things you would look for to trust somebody, and I know how involved they are in each case. So they'll stay in touch with me, I'll stay in touch with them. Not that we share anything personal or private, but hey, look for a call from so-and-so. Or, and we'll give you a choice. You don't have to use one agency, it's always patient choice or consumer choice. So we'll give you 2 or 3 names. But if you're happy and satisfied with the first person you call, fabulous. But at least if you're not, or they don't have availability, you've got someone else to call instead. So we try to do it that way.
So the other thing that I've come up against back when I was a social worker, and I used to set up services, was, and this is sort of my phrase, and Beth, who I used to do support groups with, we're all human beings caring for other human beings, and we don't always hit it out of the park the first time. It's super important that as the consumer, that you figure out if this person is the right fit for you and for what's going on. So, just because, Sandy has put a caregiver in your home doesn't necessarily mean, it doesn't mean the caregiver is bad, it doesn't mean you're bad, it just means that you didn't click. And this is such intimate care that we all provide. It is very important that you kind of check in and say, do I feel comfortable with this? Is this the right thing for me right now? And maybe it's not that person, but you gotta raise your hand. Well,
on your flyer for McLean, it says home care and hospice. Could you talk a little bit about the hospice part of that?
I would love to. The question was, the name of our agency is McLean Home Care and Hospice. And we Tully and I went back and forth about whether we have a scenario for hospice, but we're sort of focused on getting you better and safe at home. But you're absolutely right, we offer hospice services through our agency. And it is a Medicare certified hospice. And the way hospice works is, I guess the first step with anything is figuring out what it is you want your life to look like. And if you have some kind of life-limiting illness. Now, some people are gonna say, they have a cancer diagnosis, I wanna pursue every kind of treatment that's out there, I wanna go where I can, I'm going to fight this tooth and nail, and that's absolutely a choice. And some folks are saying, but the last time I was out of remission, I was so sick that I couldn't enjoy my family, that I didn't get to do the things I wanted to do, and I think I'm ready to just enjoy life and let it go. And that's where you would place a call potentially to your doctor. You should be having that conversation with your doctor, who will then determine whether you're appropriate for hospice. And hospice can be provided anywhere that you call home. So our team goes out to private homes, we go out to assisted livings, we go out to nursing homes. And it's a whole care team who we create a plan for you based on what your choices are. And that care team is a nurse. We have a chaplain who will help you with any kind of spiritual issues you may have, and we have a social worker who can help you, he can help you with figuring things out, whether it's figuring out, getting your paperwork in order or figuring out relationships. I think that together and under the Medicare hospice benefit, you're entitled to all of those things. And you get to decide, I don't really need a chaplain, thank you. And the nurse, the whole point of hospice care is comfort care. It's figuring out how you will feel better and how you will be able to live your best life. And, it's funny, I saw, it was a headline from People magazine that basically said, why isn't Jimmy Carter dead yet? Literally, that's what it said. The truth about hospice is it's generally identified for folks who are considered to have 6 months or less to live. And quite frankly, hospice does its best work the more time we have, that we work with you. A lot of people have in their head, You go on hospice and you die within days or maybe a week. But really, 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 the true benefit of hospice comes when you have time, when we help you achieve the goals that you want to achieve, and that you get to a place that you're comfortable with. And we have a medical director who is incredibly bright. And the way the Medicare benefit works is 2 physicians need to identify and agree that you are appropriate for the hospice benefit. So we hear that a little bit too, like people get put on, everybody can
Thrown on hospice.
get thrown on hospice. It doesn't work like that. 2 physicians have to agree that this is an appropriate course of action for you. And the other interesting little fun fact about hospice, some people graduate.
Yeah, just last week.
It's not unusual. Sometimes it's the extra care that you get with hospice that all of a sudden people find that extra oomph and they're no longer declining. And then they're sad because the hospice team goes away. But that's the good news. So it's really about what you want and where you're at. So thank you for asking about that. We tried to keep this on health, but I appreciate the question.
One of the biggest underutilized services.
Yes.
Absolutely, one of the biggest underutilized services. It's a benefit of your Medicare. You've
And we
paid
earn
into
it.
the system.
Yes.
And many people don't get to reap the rewards or the benefits of having a hospice team with them at the end of their life. But I will tell you, this is my plug for conversations. It's so important for you to really start to have conversations with your family and loved ones and thinking about what you would like your life to look like. Because if you have in your head a picture and you haven't told anyone else, it's probably unlikely that your picture will happen. So share what you're thinking with people who love you.
Yes.
John?
I'm Michael Kahn, a longtime practitioner in clinical psychology, marital and family therapy, and psychoanalysis. I'm trained in all 3. So I want to tell you that, first of all, thank you very much for sharing how difficult this is to work with people whose longevity has expanded. Men have increased their lifespan by 10 years over the last 30 years. We have far more elderly. And even the physicians are undereducated sometimes on how to work with us folks who are getting along. There's some virtue, I think, if you can also relay some of these things to the physicians themselves, who are moving more and more to the pharmacological end of things than the spiritual or the personal. And as a long-term academic, I'll just share with you, when I assembled 90 of my doctoral students in clinical psychology and asked them, as part of the business of the day, how many of you want to work with the fastest growing population in need in the United States? Practically everybody raised their hands. And I said, well, how many of you want to work with the elderly who are the fastest growing population? 2 people raised their hands. And 6 months later, I met those 2. And I said, are you still interested in working with older folks? No, we're working with adolescents now. So we have to be aware that the younger generation of health practitioners are also underinformed, and somehow we need to have coordinated efforts in doing that. And I didn't hear, I appreciate what Sandra and Kim and Tully and you are saying, but sometimes there are secrets in a family, grudges, quests for money, who's the favorite child, all that kind of nonsense also occurs as the population gets older. And I was just thinking about a marital and family therapist. You're all sympathetic with this idea, but a marital and family therapist who can look at the soft spots, hard spots, trauma, etc., which feeds into attitude and behavior. Okay, sorry to make it long.
I just want to say, I'm safe in this room because none of you know my child. I have a favorite. Yep.
And I probably could say that I'm the black sheep of the family, so I feel Mama said
I'm an
it's
only
here.
child, that's why.
Yeah, but I did want to just answer that for you, is that, and this is something that we talked about, and I hope I won't spill the beans, but I'll just be general about it, is that sometimes there is something larger than life than we can help or fix with. And that's why we work with other professionals like geriatric care managers, we do work with attorneys, we work with mediators. And just yesterday, I met with a woman who's having some difficulty because of cognitive issues with her husband, and she kind of thought the fix would be home care for us to come in. And I said, no, we need to stop right now. And I kind of just spelled some things out for her and gave her some resources that she could reach out to, so that as I put it to her, she could put some plans in action and actually have some safety nets for both her and her husband. So that's a really good point. One of the reasons I got certified as a senior advisor is to understand the whole aging process, but I know any of us share those resources, and we also know if there's behavioral issues, who we have to refer to. So yeah, we don't take our job lightly.
No. And I think, to your point also, is that this is certainly not the only services out there. And people have different needs. We're continually trying to find folks who will come to you in your home, because sometimes that's the safest, best place. Sometimes transportation's a problem. So, I think the moral of the story here is I'm going to harp on this, is to be a good consumer and to understand and reach out for help, hear what you're getting for advice, and then continue to learn, because there could be a psychiatrist who will come to your home. There could be any myriad of different opportunities for you, and depending on what your needs are. So this is certainly not, this is not it. This is not the whole shebang here, but this is sort of a way to get you going. And then as you develop relationships with caregivers, to your point, people don't carry signs that say, this is my baggage, figure it out. You develop relationships with people, you feel safe with them, and then you tend to open up a little bit more, and then they can help you more. So don't, keep that in the back of your head. It's, as Sandy said, there's very rarely an easy, quick fix. Yep.
Okay. So it's been a very good presentation, but what bothered me was that it seemed like it relied on the person maybe who needs the care to do a lot of planning, understanding, making sure the ball gets passed from one place to the next. Is it the geriatric care person who would coordinate all this? Is that the right?
Not necessarily. You really want to rely on your doctors as well. Okay, so when you go to your doctor, they're going to really dictate to you what's going on, because remember, you're going to need that referral from them. They're going to have to sign that. You're going to need a face-to-face so you can get home care from the doctor. So you have to rely on your doctor's offices.
I don't think you're being realistic about doctor's offices.
Well, and that goes back to what Peggy says, is that you have to be informed, and you have to educate yourself, and you have to be responsible for your health care. If there's anything that I found with educating doctors in Connecticut for the past 10 years is you have to tell them what you have found and how badly you want this and this and this. Because they're not gonna just hand it to you. Some will. There are some groups that are wonderful, and they have resources, and they have social workers, and they have people to reach out to. And some groups, no, you sit on the phone for an hour to try to get through to make an appointment. So if you're not comfortable with that doctor, find another one, because there are a lot of them, especially in this area.
But the doctor isn't going to tell you need somebody to come in and make your breakfast. I mean, you need somebody who's going to come to your home, assess what your needs are, and give you some guidance.
Right.
And it sounds to me like if you're 95 years old and gotten a little vague, and you don't have a kid down the road,
who knows?
got a problem.
Right. Exactly. So in my case, or in Tully's case, we would rely upon the physician at the annual well visit to say, you need one of our two services to come in the house. And when we get in, we can then say, whoa, things have progressed severely. Why don't you talk to Sandra? So that's why I'm saying our staff Because it's not just Tully and I. We have a number of staff behind us are educated. Like, we primarily only work with the older adult population. So we see this every single day of what is needed when they're in the home. And they're licensed. Nurses, PTs, OTs, speech
I don't
pathologists.
think you understand what I'm saying. I'm a
No,
resident.
I think a
I'm
geriatric
resident
care
here.
manager could be
And I would
helpful.
like to hear that I also can retain through McLean a geriatric care specialist who visits me and makes sure I'm getting the care I need. And I'm going to the doctor when I need to maybe, and all that sort of thing.
So I'm just gonna share with the group, the conversation is about what is a geriatric care manager? What do they do for you? Does everybody need one? It is currently not a service that we offer in our home care agency. And I think McLean's always looking to see what is the next service that people are looking for. But basically a geriatric care manager is usually a nurse or a social worker who is trained in being able to assess not only the patient before them, but their environment. And they hear from the person, what are their goals? What do they want their life to look like? And then they go and they make the phone call to any one of us on the panel to say, I think we need this. They can accompany you to your doctor's appointment. So I'm gonna ask a question. Who makes a list of questions before they go to their doctors? I know if I go to the doctors and I don't have a list, I've completely forgotten everything I thought about while I was laying in bed the night before. So that's your first step, is to be able to kind of figure out, what am I struggling with? And you're right. I mean, there are doctors who are better at it than others. I know my doctor, any communication between visits is through my chart. That's not very satisfying. But the truth of the matter is that the person, the consumer, has to say, I need more help, and they need to be able to recognize it. So there is such a thing as a geriatric care manager. That's another option for helping you in your home. And I think, we've talked a little bit about is that something we'd like to have for an M&M? What do they do? So,
And we know some very good ones,
Yeah.
just from being
And-
out in the field.
And you have to remember, this talk today was geared around what does insurance cover, what doesn't insurance cover. Geriatric care managers, excuse me one second, geriatric care managers is private pay. Unless you have a long-term insurance policy, and there are some long-term insurance policies that will pay for some of those services. So if we didn't touch on it all, then we apologize. We were kind of just focused on what would be covered by insurance. Yeah, so she's had her hand up for a while, and then we'll go. I've watched her out of my corner of my eye.
I'm not independently wealthy, maybe some are, but you haven't mentioned anything about cost. What does Medicare and your insurance cover toward this? Can we have somebody who's gonna be there forever? Does the insurance cover it, or are we good for 30 days? And then you have to stop for whatever and start again. Could you cover a little bit of that?
Sure. So Medicare is the one who sort of decides how, in many cases, Medicare and your doctor decide how long you can have services for. The way the Medicare A system is set up now is in 30-day increments, and you have to be showing improvement. If you have a traditional Medicare policy, it will cover your home health benefit, and there will not be a copay. If you have a managed Medicare product, there may be copays, and that's where every insurance is different. Copays can be different. I think outpatient Part B services, are there some?
It's very similar.
With outpatient services, traditional Medicare obviously covers your 80%. Most people have a secondary that covers your 20%, so you would have no copay. If you have a managed plan, it depends upon if you have an HMO or a PPO. If it depends upon what plan you took, if you're with your employer, if they gave a plan to you. There's so many plans and variations and combinations when it comes to a managed plan, that it's really good for you to be informed and to ask for your insurance to be checked first. As a courtesy to anybody that comes to Fox, we check your benefits first. We do it. I don't ask for the doctor's office to do it. we check first to see what your benefits are so that when we call you, we're intelligently talking to you about your benefits. So I've seen the full range. I've seen an HMO, which is not covered. I've seen high copays, no copays, low copays. I've seen it all. And so I always ask, call me first, I'll check it. It takes 2 minutes for me to check. And that's any outpatient clinic, that's any company that goes into the home like myself under your Medicare Part B. We can check your benefits first to tell you what your copay is, so you're well informed. But again, with Medicare and the managed plans, the range goes from 0 to infinity. Because it depends upon your plan. Your plan, I guarantee you, is different than everybody else in this room, and everybody else in this room probably is different. There is probably at least 100 different variations in this room. I know you're so desperate to see.
Well, it's just I'm fairly young, my husband's fairly young, we've been at this 3 whole months, and I'm coming up against, your insurance doesn't cover this. His insurance doesn't cover this. Okay, it's early on in my process. How do I find an insurance that covers this?
So you speak to a insurance person, a Medicare insurance person that does not sell one product. So if they say, oh, I work for Connecticut, stop, don't go any further. I work for Blue Cross, stop, don't go any further. Sometimes you don't have a choice though. Sometimes you are an employee of the state and they've switched 3 times in the past 3 years, okay? Luckily enough, they take what the benefits are, even though they've switched from company to company, they've still retained the same level of benefits. And that's the good thing about it. But you don't really have a choice in it. If you retired from the state and they said to you, I'm going to give you, you're a retiree, I'm giving you insurance for the rest of your life. Well, God bless you that you did that, because that's wonderful. But they're going to change, and you have to go along with it unless you want to pay for it privately. And again, not everybody can afford to do that. You're on a fixed income. So always go to a Medicare specialist that can put a list out of what your needs are. Let's remember, as we get older, we're going to need more medical resources, not less. So you don't want to take a plan that covers less. You want to take a plan that covers more, but at your time of need. My mother-in-law is 88, and how her thought process is, I'm sticking with the plan I have now because I'm not sick. I don't see the doctor a lot. But at the time, her husband was sick and saw the doctor a lot. So he was on a different plan than she was. So it's really, and you can change year to year. That's not a problem. If you're not using your benefits from your employer. But you really need to sit down with a Medicare specialist. We know a gentleman, Medicare Mike, we nicknamed him.
How do you find this person?
We have a name of somebody that we can give you guys. We can write it down. And he does not sell one product. He looks at what your situation is. You want someone to look at you individually. And that's with any service that you're getting, whether it's physical therapy, whether it's home care, whether it's non-medical. You want someone that's going to look at your situation, not what everybody else does, but you individually. Because if you're not looking at a holistic approach, that you're not going to get anywhere.
So can you tell us Medicare Mike now?
Medicare Mike.
Yeah.
Did you have this one?
Oh, I don't have, we can get it for you, but I'm gonna give you an additional resource than just one person. Your Simsbury Senior Center does open enrollment every fall, right? It starts in October and goes to December 15th, I think. So if you remember nothing else from tonight, not even Medicare Mike, oh, we have it.
I'm sure he'd be thrilled to know we're giving it out to everyone.
So, but the senior center always does open enrollment, and you do have the ability to be able to change every year. Okay, so Medicare Mike's number is 860.
What's his name?
Mike.
Mike, Medicare Mike.
Michael.
I don't know what. That's how we refer to him.
He's a nurse.
He is a nurse.
He's a nurse, so he has a very extensive clinical background.
Right, but 860-706-6735.
The other thing I just want to, I don't know if anyone, earlier in the season, we did an M&M about insurance, and we had a representative from Choices. And that's a fabulous program by the state of Connecticut. And this woman who was there she knew her stuff. And so that's also an impartial person. So I think what you're hearing is if you can find an impartial source to help you navigate which plan is best for you based on where you're at is your best bet.
What about original Medicare?
Yeah,
Yay, stay
that's the
on
gold
it.
standard.
Stay on it, don't move from it.
Well, we're a little partial to traditional Medicare.
My experience
not
has been that unless we affiliate within our professions with a group of us or across professions, we're being stonewalled by the insurance companies. We're in this conundrum where in order to get additional benefits for our patients, we have to show improvement. The conundrum is it's improvement to show that the treatment is, quote, working, but it's also, on the same token, we want additional rather than a cutoff of treatment. So I had a young man who was depressed, suicidal in ideation, hadn't tried anything yet. Blue Cross didn't want to give him more visits, so as a cost containment. So I took the parents and we went down to North Haven to Anthem Blue Cross, and we met with their team to try to argue for more visits. The team that greeted us was about 10 or 11 people. One of them was a lawyer, one of them was a clinician, and the other 7 were, quote, cost containment specialists. That was their job description.
So I think, I don't think anyone in this room thinks that this system isn't slightly broken. But, and we could probably do a whole nother night on insurance, we have done some. But I think, just to bring it around to the importance of being an educated consumer. And no one is gonna take care of you better than you will take care of yourself.
Yeah.
Anybody have any?
Quick question. 20 years ago, when I signed up for long-term care insurance, it was fairly cheap. It is not anymore.
No.
They said, oh, we can't change the rate until, we go through the insurance department, which they did many times. I think they had a person staff there regularly. Anyhow, I was told at the time, 20 years ago, that Connecticut is the most expensive state in the country for nursing homes primarily and other forms of care like in-home care. Is that still true, and why? Because some really lousy nursing homes.
We're not the most expensive. I would have to say that, and I can answer that in a most truthful way. So Home Helpers is a national franchise. We are independently owned and operated. I was in Savannah last week at our national conference. So I actually got to sit and talk with people from across the country. And I can tell you that there were some states that absolutely flabbergasted me as to their rates were much higher than what we were in Connecticut. So it's out of the horse's mouth of what they were, charging reimbursement rates. So I definitely, Connecticut is different than most states across the country. That is known for sure, but I don't know that we just hold that record of being, the most expensive right now.
So there's overutilization. So there's overutilization of benefits in Connecticut. We are one of the highest. But the good thing is that you have these benefits. So you have to look at it twofold, because in most states you don't have as many skilled nursing facilities and home care agencies that we do. We have them. You have choices, you have experts here. So you have to kind of look at it both ways, that you are going to get that level of care that you need because you are in Connecticut. You kind of balance it out. Okay, well, maybe if I went to Florida, I'm not going to get those kind of resources, and you're probably not. So, so you have to kind of balance it out. As I'm going to get more care while I'm here in Connecticut.
So I want to bring us back around to services in the home. It sounds like there are lots of folks who would love to talk about how to pay for care, and I would encourage you on your surveys to mark that down, because we can certainly have another night that kind of delves into as much information as you can give us. We can try to bring an expert here. There's someone, yeah.
Questions for Sandy. So if you have, the situation is mom lives alone needs assistance with instrumental activities or family living. Can you walk me through, if I were to call you, what would that look like? Do I identify for you what those might be, or does somebody come in from your agency to help me figure out where the hours would go? And is it 4 hours a day?
Yes, it is 4 hours for us, it is 4 days, an hour. So I would be the person that would come out, and yeah, we don't do anything sight unseen. We just don't say, yes, that's what you need, or, you know, yes, this is who your caregiver is. No, we do come out and do a home evaluation. And remember, I said earlier, in your particular case, you know, it would be talking with you and your mom. So we, even though there may be some cognitive decline, there may be some things that we can glean from her in the most respectful way, and then identify how it would be best, yes. So we can help you figure that out. I had a daughter once tell me that we could do everything in about 20 minutes for her father, and that was to come in, slap a couple pieces of meat on 2 pieces of bread, throw it on a paper plate, make sure that he took his meds, and check to see that if he had water. I thought, I'm glad I'm not. That's, you know, that there's a reality to it, but, you know, she was very time focused, and you know, we don't want anybody just sitting there twiddling their thumbs, but, you know, we also just don't want it so task-oriented.
And I think you had, one part of your question was, is it 4 hours per day, or is it, I think it's 4-hour blocks.
Well, yeah,
It doesn't have to be every
not
single
2
day.
hours in the morning and 2 hours at night. I'm sorry if I misunderstood you.
But it could be maybe 3 days a week for 4 hours, or no?
Yes.
No, so
Yeah.
if you,
The answer is
I'm not understanding her.
12 hours.
Yes, 12 hours. I was hearing it differently, 4 hours for the whole week. That's what I was hearing, so I apologize, yes.
It's just that when the worker comes out to your house, you need to plan for and expect that that worker will be with you for 4 hours.
Right, yeah.
They're not gonna come out for an hour and slap some bread.
That's not happening.
They're gonna want, you know, so, you know, the other thing that I tell folks when they're looking at getting some private care in their home is think about your loved one that you're thinking might need some assistance, or think about yourself. And I always encourage folks to kind of get a notebook going. You know, they like to play canasta. I don't know if you can do canasta with just 2 people, but I don't know why canasta came. They like to play gin rummy. They love to fold laundry. Activities that will make that person feel comfortable and safe with their caregiver. And what that does is it builds a trust between the patient and the caregiver. So as much information as you can give about yourself, if you're the one who's going to receive it, or about your loved one that you're looking for, is kind of the best way to make it a relationship that everybody will win and feel better for. I once had this client as a social worker who her mother lived with her, and she was like, oh my gosh, 4 o'clock every day, my mother is yelling at me about money, where's my purse? And she would grab her wallet and she would start pulling money out. And it was driving the daughter crazy. And we kind of talked about, you know, her mom grew up in the Depression, and money was a very important thing for her. And she needed to know that she had some. And so I encouraged the daughter, get a wallet and put 5 singles in it. And say 4 o'clock she starts to get agitated, you can hand her that wallet and she can sit there and she can count that money. You know, the goal is to find what will soothe us. And everybody's story is a little bit different, and everybody has different needs. So as much information as you can give any of these folks that come into your home, the better the service will be.
And the deadly iPhone. When you get helpers in the house, there has to be a policy that their iPhoning is limited to their lunch break, not throughout the day while they're trying to do the work with only one hand, because they're chattering away to God knows who.
Yeah.
That's right.
That's,
Being an educated consumer, setting your expectations.
yeah.
Any other questions you got?
Just talk about the scenario I'm here for my parents. I have a 105-year-old father, a 95-year-old mother. They're still at home. You know, you're kind of talking about situations where you have an acute illness, you go to the hospital, and you know you're talking about maximum medical improvement.
I'm more concerned about, my father wants to die at home. You know, he's getting weaker, but he still does his activity of daily living. He still goes upstairs, God bless him. But, you know, there's gonna come a point where I know, you know, he's not gonna be able to get out of the chair. He's not gonna be able to get to the bathroom himself, bathe himself, and he wants to be at home. So I'm just wondering what in-home care is available at that particular time for him.
Well, honestly, I think, and quite frankly, I know in conversations that Tully and I have had with physicians, this is a challenge because people are, to your point, living longer, and their needs are not necessarily clinical. They're not in need of a nurse to be there, but they want to die in their home, and they need a little bit of extra help. And I think that's where the private duty can be helpful. And as the daughter, you figure out, is it one person or is it two? Does your mother need some help? Does your father? What does that look like? And Sandy can help you figure out, you know, all of us, well, I guess I should only speak for myself, but I have better parts of the day than others. And if my children needed to get me some help, they could probably tell you, you know, this time of day is where they need help. And it could be getting up, getting washed up and dressed, and then they're okay for a little while. And maybe they need another 4 hours getting undressed into their pajamas and getting to bed. And that's kind of the beauty of private duty, is that you can decide where the needs are. And it can go up to 24 hours a day, 7 days a week, depending on, you know, what their needs are, and quite frankly, what you can afford. Yeah, and that's the rub, actually.
And you don't have to have an episode to have outpatient therapy. If you say that, you know, he's getting weaker, that's what a physical therapist does. They go in and they work on getting that endurance and your strength up so that they don't have that catastrophic fall that puts them in the hospital. That's the main focus. So we don't look at the clinical side, we look at the functional side. So we are looking at what are your activities of daily living and what are you doing? How do we help you get stronger to maintain them so you can stay at home?
And that's a conversation that I would need to have. I mean, I go to the doctor, his doctor to say, you know, and you provide order for him to get some help at home.
Yes. And basically, I mean, it's an order for exercise. It's not a script for opioids. It's an order for exercise. Who can't use exercise? Like that's like the basics of what we need to keep on continuing and to get up out of our chairs and walk and get in the shower. If you can't do all that, you know, then you do have that fall and you end up in the hospital. So there's some basic stuff, but definitely Sandy can help also.
Well, yeah, and I think you just raised one question, and we're not gonna get really lengthy with it, but as people are living longer, obviously their finances dwindle, right? Kind of just heard that, or it's both comment. And so that's definitely when you need to have, you know, a geriatric care manager, work with an attorney, have somebody be able to look at creating that plan of, you know, this is X, Y, and Z of what we have, what's the next steps. So really, that's why Peggy said the conversation. God bless you at 95 and 105, but we're having the conversations now with people who are in their 60s and 70s, right? You know, and trying to plan ahead. So you're a little bit more difficult if they've stuck their heels in, but you know, there still are people that can help you have, you know, those conversations. And I used to do a talk on planning conversations. The conversation piece that Peggy's talking about is, so you as an individual identifying your needs, but as a family, if you are children and have to have conversations with your parents, there's actual program with the Alzheimer's Association on having those difficult, you know, conversations. You yourself can go online or look. Many times that Simsbury Library has them, so that you know how to plan about having those difficult conversations.
And I think, you know, as difficult as it may be as we age to have that conversation with our children, it's equally difficult for our children to say, Mom, I'm worried. You know, and sometimes the roles get switched, and nobody's super comfortable with that switch. But the best thing that you can do is to talk about it and say, oh, this is so hard for me. But I want this to look good, and that's the goal, right? We're here because we want to stay safe at home, and it takes a village. It really does.